Okay, I will talk about the diabetic emergency and chronic complication. Now, in the last, class of the last semester, we have started the discussion on diabetic ketoacidosis and hyperosmolar non-ketotic coma. So those are two very, very important diabetic emergency, which we already talked. So in today's class, we'll start with lactic acidosis and hypoglycemia. These are the diabetic emergency, also known as acute complications of diabetes mellitus. After that, I'll enter into the chronic complication. Now, chronic complication can be divided into two parts: macrovascular complication and microvascular complication. Regarding the macrovascular complication, it is because of atherosclerosis formation, because diabetes is a very important risk factor for atherosclerosis. Whereas regarding the microvascular, just remember these three important points: diabetic nephropathy, diabetic neuropathy, and diabetic retinopathy. So these are the main points we are going to highlight in this discussion. Let's move on. Let's start with lactic acidosis. Okay, see that lactic acidosis occurs in a patient of diabetes if they are having biguanide therapy. Now, give me the examples of biguanide. Yes, which drugs are biguanide?
Metformin.
Excellent. Metformin. Okay. Fenformin and metformin. But fenformin is not used at all these days because of this dreadful complication known as lactic acidosis. And it is a very good thing to know that metformin has a very, very decreased chance of adverse effect or side effect. Nevertheless, in few of the patient, it has been reported. The risk in patient taking metformin is extremely low, provided that the therapeutic dose is not exceeded and the drug is withheld in patient with advanced hepatic or renal dysfunction. But sometimes what happens, people take higher dose than the doctor prescribe, or the doctor themselves prescribe very high dose because of some reason. And sometimes the patient is having, sometimes the I'm going to mute you all now. Okay. Problem. Okay. Now, sometimes what happens, the the patient is having some other problems like renal dysfunction or renal diseases or liver diseases. Then also, the drug cannot be metabolized or cannot be excreted properly, or it is taking a longer time to do so. Then chance of adverse effect. Regarding the diagnosis of lactic acidosis, we need to do arterial blood gas analysis, ABG. Okay, ABG. When we do ABG, now see there what we see. We see metabolic acidosis, because lactic acidosis is a type of metabolic acidosis. Now, the hallmarks of metabolic acidosis would be pH. Okay, pH will be low. We all know that pH is less than 7 point, okay, 35. That is the first thing. Second one, the serum bicarbonate level. Okay, serum bicarbonate level. This is bicarbonate is very low. It is very low. It is usually, the range of bicarbonate is around 25 milliequivalent per liter. So somewhat it is less than 25. Let's say that. And then PCO2, right? PCO2. We don't need to concern about that because that may be normal or it may be in the outside range. It depends on the situation. So to diagnose metabolic acidosis, we just need these 2 points. Bicarbonate is very low and pH is low. Okay, remember that. And this is because of excessive collection of lactic acid here. Now the question comes to you, why this biguanide therapy causes lactic acidosis? And in the literature, it is mentioned that this particular drug biguanide is blocking gluconeogenesis. Okay, it is blocking gluconeogenesis. So it is blocking the pyruvate carboxylase enzyme, and as a result of that, lactic acid will be accumulated. Now, treatment is by rehydration and infusion of the bicarbonate because it's metabolic acidosis. So bicarbonate is the treatment, and person is dehydrated. So you should give a lot of IV fluids, and mortality is very high here, is in excess of 50%. So this is a serious situation. But luckily, metformin doesn't have a lot of incidence of this type of complication. Now let's move on. Now, another, important complication which we are going to talk is hypoglycemia. See there, hypoglycemia is defined as blood glucose less than 63 milligram per dl, or if I talk in millimole per liter, it is less than 3.5 millimole per liter. Okay, whatever way you answer, it will be correct. Whatever way. Okay. This is important point. Now, the question comes to you, why diabetic people develop hypoglycemia? Isn't it? Diabetes is not hypoglycemic situation. Diabetic is hyperglycemic situation. So why hypoglycemia occur in a case of diabetic? This is the point you need to understand from this discussion. See this. When hypoglycemia occurs in a case of diabetes, it is a result of treatment and not a manifestation of the disease itself. So there are different type of drugs we are going to use, like insulin, like sulfonylurea. Okay, so these are the important drugs. Both of these cause hypoglycemia. Even meglitinides cause hypoglycemia. It occurs often in those treated with insulin and occasionally in the sulfonylurea drug. That's what I'm talking right now. Let's move on. Now, this is a very important slide. Okay, so please pay attention here. What are the causes of hypoglycemia in the case of diabetes? If a person miss the meal, okay, takes inadequate meal or delay the meal, but at the same time he is taking medicine in the appropriate time, and if he indulges himself or herself in a excessive exercise or workout, there is a high chance of hypoglycemia. So diabetic person should not miss the meal, should not miss lunch or supper, okay, or snacks. They should eat, okay, quite frequently. The volume of the food should be low or less, but frequency should be maintained along with the medicine. If there is unexpected or unusual exercise, okay, remember exercise will, okay, utilize the glucose. Glucose can enter into the cell even without the help of insulin during exercise. So that can also lead to hypoglycemia. You know, exercise is good for the diabetic patient. We are not saying that, okay? But if they are doing unusual type exercise, heavy exercise, suddenly, then there is a chance. Alcohol. Alcohol is an important cause of hypoglycemia. Anybody can tell me how alcohol causes hypoglycemia? Anyone? Yes?
Yes, sir, because he will lose
It
his
lead to decrease.
he will have
It has
anorexia, he will
empty.
not eat. So
It
that's
lead
why.
to decrease gluconeogenesis.
Okay. So see that I'm getting two answers from the students here. Okay. One, it decreases gluconeogenesis. Another, it causes decreased appetite. Okay, anorexia. Now I'll add something more there. Both of those are correct. Okay, both of those are correct. I'll add one more. Alcohol, like ethyl alcohol or ethanol, causes a lot of sugar. Okay, it causes sugar actually. Sorry, it has sugar. So when that sugar goes into the blood, that sugar suddenly stimulate the beta cells of the pancreas to release more insulin. Now that insulin will cause hypoglycemia. This is also one more reason which is given in the literature. Definitely, it is blocking the conversion of glycogen into glucose in the liver as well, and it doesn't allow the new glucose to form. So all these points are important in causing hypoglycemia. Okay, this is an important question which is asked to you by the teacher. Alcohol doesn't only cause hypoglycemia in the diabetic, it also causes hypoglycemia in the normal person. In the normal person also, if they consume a lot of or large amount of alcohol. Another reason may be error in oral anti-diabetic agent or insulin dose, schedule, or administration. If they are taking higher dose of sulfonylurea, which is not prescribed by the doctor, or if the doctor has wrongly prescribed the medicine, if insulin is taken excessively, okay, there is a chance. If there is a poorly designed insulin regime, particularly predisposing to nocturnal hyperinsulinemia, there is a chance. Poorly designed insulin regime, okay, means the the faster acting or the short acting insulin is in excessive amount than the longer acting one, then it can quickly leads to drop in blood sugar. Lipohypertrophy at the injection site will cause variable insulin absorption. So you don't know, okay, how much insulin is getting absorbed. So it will mislead the patient. Gastroparesis. Gastroparesis. You see that there is no peristaltic movement of the stomach. And this occurs because of chronic complication of diabetes. One of the complications is neuropathy, like autonomic neuropathy. So during that time, food is not getting absorbed properly, but the patient is taking the medicine, so there is a chance of hypoglycemia. If malabsorption causing problem like celiac disease coexist with the patient, there is a higher chance. If other endocrine disorder like Addison's disease are there, there is a higher chance. And don't forget about the last one. This is the factitious hypoglycemia. Patient themselves deliberately injected insulin, and insulin is a hypoglycemic agent. So this type of patient can also present to the hospital, and they can cause a lot of headache to the doctor. We really cannot diagnose it in time, why? What's the mechanism of hypoglycemia? So probably we need to admit this type of patient to the hospital under observation, and then we can diagnose them. So these are the causes of hypoglycemia in diabetes. Now, another important part, what are the clinical features? How hypoglycemia is diagnosed according to the examination. These are the autonomic features of hypoglycemia, like sweating, trembling, pounding heart, means palpitation, hunger, a sense of hunger, and sense of anxiety. These are all because of sympathetic nervous system stimulation. Another one is neuroglycopenic symptom. Now, when hypoglycemia is severe one and a long-lasting one, our brain will suffer because brain totally preys on glucose, so that the person will have confusion, drowsiness or sleepiness. There is difficulty to speak as well. There is inability to concentrate or focus. There is incoordination. There is tremor as well, and the person will often be irritable or develop angerness. Okay, so these are neuroglycopenic symptom. Remember, these occur a little bit later. In the beginning, always autonomic symptoms start, and neuroglycopenic symptoms come later if it is not treated in time. Some non-specific features are nausea, vomiting, tiredness, and headache. Now, these symptoms differ with the age. If this hypoglycemia occurs in children, then they are usually irritable in the beginning. And if they occur in very old people, they usually develop neurological symptom. Now, let's move on. What are the common morbidities of severe hypoglycemia in a diabetes? Why this hypoglycemia is a dangerous situation to have in a patient of diabetes? Now, remember one thing, let me repeat that again. All of us know diabetes is a hyperglycemic situation. So our people may not understand why hypoglycemia occur. So it's our job to convince them, yes, you should not do this type of things, then there is a high chance of hypoglycemia. Now, what we are talking here, if hypoglycemia occur, what damage can be done to the patient? Regarding CNS or central nervous system, okay, these are the morbidities. See there is impaired cognitive function. Okay, patient cannot really focus. Transient ischemic attack or even stroke can occur because of hypoglycemia. Brain damage, if there's a severe hypoglycemia for a long time, then only permanent brain damage can occur. Otherwise, it can manage somehow. Focal neurological lesions, again in severe hypoglycemia, that's why it is written they are rare. Patient can suffer from coma, patient can suffer from convulsion or seizure, and over a period of time, if brain is already damaged, there is intellectual decline as well. So brain is one of the main organ which is suffering in case of hypoglycemia. What about the heart? There may be cardiac arrhythmia and there may be myocardial ischemia. Okay, ischemic features can also occur because of hypoglycemia, because glucose is all about the nutrition to the most of the organ. Regarding the eye, there is worsening of retinopathy. Diabetic retinopathy is a chronic complication of diabetes. If the patient is already having that, the further worsening of the symptom occur. And accidents are quite common in case of hypoglycemia because patient is drowsy, patient is sleepy. Just remember, if that patient is driving, there can be severe accident. So these are some of the morbidities. Now let's move on. Now let's talk about how to treat. Confirmation is very easy. Confirmation is done by measuring blood sugar level. Okay, if it is less than 3.5 millimole per liter, the diagnosis is done very easily. And another way of diagnosis is examining the patient, taking good history and physical examination. We have just discussed that. Now, how to treat? Now, there may be two situations here. One, when the patient is having mild symptoms of hypoglycemia, patient can treat themselves. Okay, self-treatment is a possibility. So how to do that? Probably that is the only situation in a diabetic case where they can take some sweet thing, like glucose drink, a good cup of tea also with plenty of sugar, some tablets which are sweet again, or confectionery, like a chocolate things or candies and things like that. So this is known as the self-treatment of hypoglycemia in a case of diabetes. So you have to tell them to the patient, because all the patients of diabetes know sugar is absolutely contraindicated to them, and this is the only situation where they can take this fast-acting sugar. This should be followed with a snack containing complex carbohydrate, which is slowly absorbing. Now, another situation is when severe hypoglycemia is there, patient is usually drowsy or maybe in coma or unconsciousness. So external help is required. Sometimes patient may fall on the ground. Sometimes patient may fall on the side of a road, and somebody else will take this patient to the hospital. So these are very important points. So it is often advisable to the patient of diabetes that they should, put a card in their purse or in their pocket, writing that I am a patient of diabetes. Okay, if something happens to me, please take me to this particular center. If they write like that and put in their pocket or purse, they can be revived in this type of situation. This is also we need to tell to our patient. Now let's come to the point. If a patient is semi-conscious or unconscious, how to treat? We need parenteral treatment. This parenteral treatment is done by giving IV 20% dextrose, around 75 ml. This is equivalent to 15 gram of glucose. Okay. This is 0.2 gram per kg in children But for adult, you don't need to calculate like this per kg. You straight away give this amount of glucose. You can also use IM glucagon. Now, what is the role of glucagon here? Yes, what glucagon is doing?
Glycogenolysis.
To decrease
Convert
insulin.
Raise the
glycogen to
glucose level.
glucose.
Good. Okay,
Increase the
so
glucose.
exactly, glucagon is a hyperglycemic hormone. Okay, it increases blood sugar level by different mechanism. It promote glycogenolysis, exactly opposite function of insulin. So you already know. That's why we are using glucagon here to increase the blood sugar level. If patient is conscious and able to swallow, then you can give oral refined glucose as a drink or sweets, or you can simply apply the glucose gel or some of the sweet jam or even honey to the buccal mucosa, so that sugar can be quickly absorbed and the patient will be revived. So treatment is not that challenging, Diagnosis can be challenging if you do not think in the right direction. This is about hypoglycemia. Now, the second part of the lecture. What are the long-term complications of diabetes? I already, elaborate in the beginning of this lecture. There are two types of long-term complication. One is called macrovascular complication. Another is microvascular complication. Macrovascular complication is all about atherosclerosis in a different part of the body, in different blood vessels. So that different type of clinical feature will be there. We'll talk shortly about that. And the other are microvascular complication like retinopathy, neuropathy, and nephropathy. Now let's come to the point. The duration and degree of hyperglycemia play a major role in the production of complication. Absolutely. And we need to explain this all the time to the patient. How long that person is diabetic, and what is the level of sugar in the blood, what is the level of HbA1c or glycosylated hemoglobin there. It all depends. Okay, or these are the major factor which determines the complication, how quickly complication will come. Better diabetic control can reduce the rate of progression of both nephropathy and retinopathy. Better diabetic control means blood sugar should be within normal limit with the help of medicine or with the help of physical exercise or with the help of diet control. Then they can postpone the progression or development of nephropathy and retinopathy. Now see there, they have done different studies regarding this, and many studies have shown that there is 60% reduction in the developing complication over 9 years when the hemoglobin A1C was kept at around 7% in type 1 diabetes. Now 7% is slightly higher than the normal range. Normally, it should be less than 6.5, but nevertheless, it is not that very high. So the chances of complications are much more reduced if we maintain HbA1c in this range. Now, let me ask one question. What is the importance of doing HbA1c here? What is the importance?
Sir, it will show us the glucose
Sir,
level
it
for
will
the
show
past
the
3
previous
months.
2 to 3 months diabetes.
3 months glucose level. will show.
Long
2 to
term
3
of
months.
diabetes for them.
Very
It will
good.
show in the last 3 months how tightly the blood glucose is controlled.
Glucose,
Very good.
blood glucose are attached to the RBCs.
Very good. Okay, all of the answers are correct. Excellent. So what is glycosylated hemoglobin? If glucose is excessive in the blood, that glucose will stick, okay, on the surface of RBC, okay, on to the hemoglobin. That is glycosylated hemoglobin, non-enzymatic connection. If the patient has very poor control in past 3 to 6 months, then HbA1c would be higher. If the patient has a good control of blood sugar, then HbA1c, okay, will be in the normal range. So that is the important point. Let's move on. Now, what are the other factors they are associated with increased mortality and morbidity in people with diabetes. Diabetes itself is a very important risk factor for a lot of the condition. But if this patient is having other risk factor along with diabetes, then the chances of death or chances of the disease are much more higher. Now, let's talk about that. Duration of diabetes is one thing. If a patient is just diagnosed with diabetes, okay, the chances of complications are very less, rather than if the person is having diabetes for 15 to 20 years, already a lot of complications are there. Early age at the onset of disease, definitely. By the time patient is coming to he's already 40 years, and this is a type 1 diabetes. Now you are getting what I mean. Type 1 diabetes usually start in the childhood period, so already, okay, a lot of time is there, so more chance of development of complication. High glycated or glycosylated hemoglobin is a definite risk factor for the complication development. Raised blood pressure or hypertension, this is never a good combination. Hypertension and diabetes together, there's lots of problems occur. Mortality and morbidity will really increase in this situation. Proteinuria or microalbuminuria, now this is renal involvement, okay, in a case of diabetes, means already diabetic nephropathy has developed. Dyslipidemia, if lipid level is high in a case of diabetes, they can quickly develop atherosclerosis and a lot of other problems. And obesity is also not a good combination with a diabetic patient. Having said that, type 2 diabetes people are usually obese, okay, and obesity is also associated with hypertension. It is associated with hyperlipidemia and type 2 diabetes as well, so not a good combination to have. Now see there, another important question, especially in the Viva exam: what are the causes of death of a diabetic patient? How a diabetic patient may die? What are the causes of mortality? Now see this, these are the approximate proportion, okay, of death in a diabetic patient. Cardiovascular event tops the list. Almost 70% of the time, cardiovascular disease, okay, are responsible for the death in a diabetic patient. And you all already know what is the reason behind it. Yes, what is the reason?
Due to
Atherosclerosis.
atherosclerosis.
Atherosclerosis only.
Atherosclerosis.
Macrovascular complication.
Very good. Atherosclerosis and microvascular complication, which is causing coronary artery disease or ischemic heart disease. It is developing atheroma in the coronary artery, and that is blocking the blood flow to the heart, leading to myocardial infarction. And all over the world, myocardial infarction is the #1 killer. Diabetes is extremely important risk factor for atherosclerosis. So look at the connection here. At the same time, if the person is a smoker, if the person is having hypertension, or if the person is dyslipidemic, the chances are much more higher. Second is a death from renal failure. Okay, death from renal failure. It is also very common these days. The incidence of diabetic nephropathy is increasing day by day. Cancer. Okay, diabetes itself will not lead to cancer, but probably this is a comorbidity which is related. Infection is quite common in diabetes because it is a relatively immunocompromised situation because of so many factors. Diabetes, over a period of time can result in atherosclerosis. Atherosclerosis will lead to decreased blood flow to the shortened organ. High blood sugar itself leads to increased thickness of the blood, that can again lead to decreased blood flow to the shortened organ. Okay, and that area definitely will have high chance of infection. Diabetic ketoacidosis can kill the patient, and some other which are not mentioned here. So many factors are related with it. Okay, even accident can kill the patient. Let's say if the patient is having hypoglycemia, which is in connection with the diabetes, okay, that can kill the patient. So this is in association. So we can list that as one of the factor for mortality as well. Now, let's enter into another important part. What is the pathophysiology of this chronic complication? Why in diabetes these chronic complications are so common to occur? Why there is atherosclerosis? Why is there nephropathy, neuropathy, and retinopathy? Okay, so let's try to know something about that. See here. The following consequences of hyperglycemia may play a big role. Like there is non-enzymatic glycosylation of a wide variety of protein like hemoglobin, collagen, LDL, and tubulin, which is present in the peripheral nerve. Now, what happens? Glucose will stick to these different types of protein. Now, the size of these proteins, okay, will become bigger. As a result of that, they can cause a lot of problem. They may become dysfunctional, or they can easily stick to certain other substances. So this is one of the major factor. Another one, abnormal microvascular blood flow, impairing the supply of nutrients and oxygen. Definitely. And that is done by different types of vasoconstrictor, which are increasingly synthesized inside the blood vessel, like endothelin, okay, and different thrombogenetic factor. At the same time, there is endothelial damage as well. So what happens now? There is thrombus formation, there is narrowing of the blood vessel, and all of these will cause ischemia. Other factors include the formation of reactive oxygen species, a reactive oxygen radical, and synthesis of transforming growth factor beta and vascular endothelial growth factor. Now, they are responsible for new blood vessels formation. Especially important in a case of diabetic retinopathy. We'll study that later on. In diabetic retinopathy, in the beginning there is ischemia, there is some outpouching of very small blood vessels, which is known as aneurysm formation. Later on, there is a synthesis of new blood vessels. So these new blood vessels are not good. We think they are good for the patient, but actually what happens? They are quite friable. They can rupture easily. There is leakage of the blood. Okay, there are different spots of the hemorrhage. They can easily leak the protein there. So all other problems will happen. Let's move on. Now see here. Okay. What are the macrovascular complications? So many times we have repeated this particular knowledge. So it leads to atherosclerosis. There's no doubt about it. If atherosclerosis occurs in the coronary artery, myocardial infarction occur, which is 3 to 5 times common than in general population. If atherosclerosis occurs in the cerebral blood vessel, stroke occurs, and stroke is twice as likely as in the general population. Women who are having diabetes lose their premenopausal protection from coronary artery disease. Now, we have already studied this. Coronary artery disease is not very common in women of the reproductive age group. Okay, they are quite protected because of the from the atherosclerosis. But if they are having diabetes, that protection is lost. That means they can still die from the heart attack or myocardial infarction if they are having diabetes. Okay, in the reproductive age group. Amputation of a foot for gangrene is 50 times as likely than the general population. And this is because of peripheral arterial disease. Peripheral arterial disease is also associated with atheroma. So these are macrovascular complications. Let's talk about microvascular complication now. You all know there are 3 important organs which are affected by microvascular complication. They are retina, kidney, Okay, uh, retina, kidney, and the nerves or the nervous system. So let's talk about each one of them. Diabetic retinopathy, diabetic nephropathy, and diabetic neuropathy, they tend to manifest 10 to 20 years after the diagnosis. So please mute yourself. So they occurs after a long time of diagnosis of diabetes, around 10 to 20 years. And especially if the blood sugar is very tightly controlled, it can still occur later than that. And if blood sugar is not tightly controlled, they can occur earlier than that. Okay, so these are the important points. Now, they present earlier in older patient, probably because these have had unrecognized diabetes for months or even years prior to the diagnosis. Absolutely true. I will explain this by giving one example to you. If a person is diagnosed with type 2 diabetes when he is 50-year-old, probably he had been diabetic for a long time, and was not diagnosed. He never went to hospital. That is a possibility. So by the time he's diagnosed, he's already diabetic for 5 to 6 years, something like that. So the chances of development of complication depends when diabetes start in the patient. It doesn't depend when diabetes is diagnosed. Now, let's start with diabetic eye disease. Okay, this is a broader term, and retinopathy is a part of diabetic eye disease. But it doesn't only cause retinopathy, it causes so many other problems in the eye. Okay, so let's talk about them one after other. Diabetic retinopathy, diabetic eye disease, is a common cause of blindness. This is a common cause of blindness. So there are different mechanisms why blindness occurs, because it damages retina. Okay, there is a one area in the retina which is known as macula. Okay, or fovea centralis is there in the macula. If edema occurs in the macula, then there is acute loss of vision occurs. There is hemorrhage occurs in the retina. Okay, there is necrosis of the nerve fiber which develops in the retina. There is detachment of the retina occurs. All these are causes of blindness, which is caused by diabetic eye disease. See here. Diabetes affects the eye in a variety of ways. One is diabetic retinopathy, which lesions developing in the retina and in the iris. These are the parts of the eyeball. So let me quickly talk you about that. Our eyeball, okay, has three layer or three coat. The outermost coat or layer is known as, what is the outermost layer of the eyeball?
Cornea.
Sclera.
Both of you are right. Actually, sclera is present, okay, on the peripheral area, and cornea is present at the center of the eyeball. Okay, cornea and sclera both has to be told. What is the middle layer? What is the middle one? Uvea. Okay, uvea. Exactly.
Right.
Uvea or uveal tract. There are different parts of the uvea. Choroid, iris. Okay, these are the parts of the uvea. And the innermost layer is called retina. Innermost layer is retina. So there are the three layers or coat of the eye. Now see this, if retina and iris are affected by diabetic retinopathy, we'll have big problem. Second type of problem occur is the refractive error. Now the lens will have problem. The reason for this is hyperglycemia. Diabetes is all about hyperglycemia or excessive blood sugar. Now that is a osmotically active substance. So as a result of that, there is imbalance in the osmolarity between the different compartments, so that excessive, a fluid may enter into the lens of the eye, resulting in refractive error. The common type of refractive error is hypermetropia. Now, I want to Here are some answers. What do you mean by hypermetropia? Anybody?
Sir, the near things will be looks blurred and the distance objects will be looks clear, sir.
Very good.
They
Yes,
will
yes.
always change glasses because they will not satisfy by one type of glasses.
People in the near thing look better and the far thing look right.
Okay. Now listen here. This is the important topic in ophthalmology, and you are going to study that in the ninth semester. Next semester. But we don't wait for that semester to come because the term is right here in front of you. So at least you should know the meaning of that. The refractive error are mainly of three types. One is called myopia, second is hypermetropia, and third is called astigmatism. Astigmatism is an entirely different type of refractive error. Now, myopia is also known as nearsightedness. Hypermetropia is known as farsightedness. Means in myopia, the person can see the near thing easily, but not the far thing. Whereas in hypermetropia, the person can see the far things much better. But when the person is trying to see the near things, the image doesn't form on the retina. The image form behind the retina. So the image is blurred. This is hypermetropia, also known as farsightedness. So let me write that term so that you will not be confused. Okay, farsightedness. Okay, means far. The thing which is a bit far away can be seen easily. The thing which are near cannot be seen properly. And another student was also mentioning it very correctly in the history. If I ask properly, they keep on changing their glasses because of the change in refractive error. This is a very important history to take in a case of diabetes. Let's move on. Cataract and glaucoma are quite commonly formed, are quite commonly developed in a diabetic case. Cataract is a opacification of the lens. Lens become white, that is called cataract. And diabetic people develop cataract quite commonly, as well as glaucoma. Glaucoma means, what is glaucoma? Yes, let me quickly ask this question.
Increase intraocular pressure.
Increase intraocular
Two
pressure,
types.
Increase intraocular pressure
opening the
may drainage system defect or
Open
increase
glaucoma,
product.
close glaucoma.
Exactly, absolutely correct. Increase intraocular pressure, okay, because of excessive aqueous humor, which is present in the anterior chamber of the eye. That is called glaucoma. Along with that, glaucoma patient has to be, some visual problem. That is a part of glaucoma definition. We'll talk about that later on. Another part of diabetic eye disease is third and sixth nerve paralysis. Okay, third is oculomotor nerve, sixth is abducens nerve. They can become involved as a result of neuropathy, and we all know what are the functions of this nerve. Third nerve, apart from SO4 and LR6. Let me write that. See, this is the way, okay, I teach to my students so that by the time the exam comes, every one of them will know these functions if they pay attention, of course. So apart from SO4 and LR6, all other extraocular muscles are supplied by third cranial nerve. Now, what is the meaning of this SO4 and LR6?
Superior oblique muscle.
superior oblique lateral rectus.
Absolutely. Superior oblique. This 4 is a fourth cranial nerve or trochlear nerve. So superior oblique is supplied by fourth cranial nerve. Lateral rectus is supplied by sixth cranial nerve. All other remaining are supplied by third cranial nerve. Okay. Now, if you remember like that, the answer should be very easy for you. Just take a moment and tell to the examiner. Move on. Now, what is the exact mechanism by which eye is involved in a case of diabetes? Let's talk about it. To be very precise, the exact mechanism by which diabetes causes retinopathy remains unclear, but several theories or hypotheses are there. Okay, let's talk about those hypotheses now. Number one is platelet and blood viscosity. You can also call it platelet and blood viscosity hypothesis. Now, what happens in case of diabetes? There is increased aggregation of the platelet. Platelet becomes more sticky as a result of excessive presence of blood sugar, or because of the excessive, viscosity of the blood. There is high chance of aggregation of the platelet. Okay. Now, what happens? There is high chance of thrombus formation easily, and that can result in ischemia. Okay, this is one of the factor in retinopathy development. Second is the aldose reductase pathway hypothesis. Now, whenever glucose is excessively present, glucose will, undergo into some other pathway of metabolism. So this is called aldose reductase pathway. This glucose or sugar will change into alcohol. This sorbitol is a type of alcohol. Okay, and this is the enzyme which convert glucose into sorbitol, aldose reductase. That is the meaning. So this sorbitol will be formed and it is collected, okay, inside the neurons of retina. Now, when this sorbitol is collected, those neurons or those capillaries, there are lots of capillaries inside the retina, they will lose the autoregulation. Now, this autoregulation is very important function there. This is especially done by some important cell known as pericyte. Pericyte. Let me write that for you. These pericytes are present, okay, on the wall of the capillary actually. Pericyte, you can remember that. Now, what happens? These pericytes cannot auto-regulate the functions of this capillary. As a result of that, the capillary will become weak in that particular area and they can develop aneurysm. They can develop aneurysm. These are called microaneurysm, which is very common in case of diabetic retinopathy. There are two important stages of diabetic retinopathy. One is called background diabetic retinopathy. Another is called proliferative diabetic retinopathy. In background, the chances of aneurysm formations are very, very common. Let's move on. Now, another important mechanism here is macular edema. Now, macula, okay, is the area in the retina which is responsible for acute vision, which is responsible for sharp vision. If there is edema formation in the macula, which is very common in a case of diabetic retinopathy, then the person will lose the vision. So this is one of the very important cause of loss of vision in diabetes. Another is hypoxia as a result of ischemia. So there is infarction of the nerve fiber inside the retina and it looks like a cotton wool spot. This is an important term in case of diabetic retinopathy. If they ask you what is the mechanism for cotton wool spot, you can answer because of the infarction of the nerve fiber in the retina. And after that, there is no circulation in exoplasm. So that area looks like cotton wool spot. Another important point is neovascularization or new blood vessel formation. How? Listen here. This retinal ischemia trigger the production of vasoproliferative factor like VEGF, vascular endothelial growth factor, which stimulate new vessel formation. These new vessels are very friable and weak. They can rupture easily and there is leakage of the blood there. This results in collection of blood inside the retina. There are different terms mentioned there in the textbook. So these are the different mechanisms. Now let's see some of the picture which will show the same thing here. This is non-proliferative diabetic retinopathy, also known as background diabetic retinopathy, and this is a proliferative diabetic retinopathy. Now see here, these are aneurysm, microaneurysm formation, hard exudate. Hard exudate means leakage of the protein or substance there, and these are the different areas of hemorrhage inside the retina. Now, just pay attention or look carefully here. This area is called the optic disc. Optic disc, and these are the blood vessels. Okay, these are the branches of the retinal artery or central retinal artery, and the tributaries of the central retinal vein. And this is the retina. This whole area is called fundus. Now, this is the advanced stage of the diabetic retinopathy, which is known as proliferative diabetic retinopathy. Look at the formation of new blood vessels here. Okay, angiogenesis has occurred here. They can rupture very easily and cause a lot of other problems. Now, this is a much better picture or fundoscopic picture which describes diabetic retinopathy. This is the optic disc. You can clearly see. Okay, these are the blood vessels which are coming out from there. See this? This is known as macula. This is the macula. The central part of the macula is known as fovea or fovea centralis. This is responsible for the acute vision. If this area is edematous, okay, or involved, or if bleeding occurs here, for example, okay, or some abnormal thing occurs here, the person will lose the vision. These are hard exudate or proteinous substance which are leaked. These are hemorrhagic dot, okay, and these are microaneurysms. You have to see very carefully here, okay. So these are the different components of diabetic retinopathy. Now, what is the treatment? Is treatment available or not? Can we able to treat this patient or not? Definitely, treatment is available. Okay, the first thing is prevention or postponing the development of diabetic retinopathy, and that is done by tight glucose control. And glucose control is done by medicine, diet control, and physical exercise. 1% reduction in hemoglobin A1C reduced the risk for retinopathy by 31%, and a 10 millimeter mercury reduction in systolic blood pressure reduced the photocoagulation or vitreous hemorrhage by 11%. This is excellent, data which is found out by different researches, and it clearly tells us if sugar is tightly controlled, okay, the chances of risk of retinopathy is drastically reduced, and decrease in blood pressure along with tight sugar control also leads to decreased chances of vitreous hemorrhage and decreased chance of treatment like photocoagulation. This photocoagulation is a treatment which is done for diabetic retinopathy. Now, another point, glycated hemoglobin level should be maintained less than 7%, okay, to minimize the chances of retinopathy. So this is our target. If it is 7.5% or 8, you should never be satisfied. Okay, something is wrong there. Either patient is not taking medicine properly, or either you are not prescribing the medicine properly, or patient is eating anything, whatever they like. So something has to be changed. Another type of therapy is VEGF inhibitor. This is vascular endothelial growth factor inhibitor. Okay, now see there, these are the monoclonal antibody. Okay, aflibercept, ranibizumab, and bevacizumab. So these are a bit of a difficult name for you to remember. Okay, so you can simply remember the VEGF inhibitor in the beginning. Later on, when you revise, these names will be quite familiar for you. So they can be used, okay, in the treatment of diabetic macular edema. And another important treatment is laser photocoagulation and vitrectomy. We can go for that. Okay, let's move on. Now, After talking about a diabetic retinopathy, let's enter into the diabetic kidney or diabetic nephropathy. Another very important microvascular complication in a long-term diabetic patient. The first thing, how kidneys are damaged. Okay, how kidneys are damaged in case of diabetic disease. The kidney may be damaged by diabetes in three main ways. These are glomerular damage, okay, ischemia resulting from hypertrophy of afferent and efferent arterioles, and ascending infection. So let me elaborate a little bit on them. Glomerular damage. Now, glomeruli are the special type of capillaries which are present in Bowman's capsule, and these glomerular, you know, capillaries are responsible for filtration, okay, of the blood. So if they are damaged themselves by the different mechanism, there may be high chances of proteinuria, hematuria, okay, and all those different problems. Ischemia resulting from hypertrophy of afferent and efferent arteriole is another big problem there. Now, decreased amount of blood flow will occur. There is decreased pressure development in the glomerulus as well. Okay, we'll talk about that. And being a relatively immunocompromised situation, there is high chance of pyelonephritis and other ascending infection in case of diabetes that can again damage the kidney. Now, let's move on. There are three major histological changes which occur in the glomeruli of patients with diabetic nephropathy. So these are glomerular pathology which develop in diabetes. Now, what are those? First, there is expansion of the mesangium. Mesangium is a intercellular space, okay, in case of nephrons. They are directly induced by hyperglycemia, perhaps via increased matrix production or glycation of the matrix protein. Now see there, so these are the connective tissue substances which are already there in the mesangium. Glucose will go and stick to these, okay, and mesangium is expanded. This is occurring in glomeruli. Second, there is thickening of the glomerular basement membrane. Again, the filtration will be a problem here. And third, there is sclerosis of the glomeruli, which is caused by intraglomerular hypertension. Now, this intraglomerular hypertension is induced by dilatation of the afferent renal artery, okay, or from ischemic injury induced by highly narrowing of the vessels supplying the glomeruli. So what is the meaning? Let me repeat again. Intraglomerular hypertension is induced by dilatation of the afferent renal artery. So there will be, increased amount of blood flow, and over a period of time, the wall of the glomerular capillaries will be sclerosed or will get harder. Okay, and that is a part of the pathological process. Now, how we identify that, isn't it? This is the pathophysiology we are talking about. But how to identify? If we take a biopsy from there and send to the lab, what we see there? We will see one of the substance which is collected there, and that is known as Kimmel-Still-Wilson body. Kimmel-Still-Wilson body or nodule or lesion. Please remember this. This is a very, very important MCQ question in different exams. This is a hallmark of diabetic nephropathy. So if they give you a long clinical case, okay, and somewhere there is a term called Kimmel-Still-Wilson nodule or lesion, without any doubt, they are trying to ask about diabetic nephropathy. Now, clinically, how we, guess or suspect diabetic nephropathy development. See here, diabetic nephropathy is a clinical syndrome characterized by the following features. One is a persistent albuminuria, means loss of albumin in the urine. Albuminuria, that is more than 300 milligram per day or more than 200 microgram per minute. This is a difficult way to remember. So it is easier for us to remember like this. More than 300 milligram per day loss. That is confirmed on at least 2 occasions, 3 to 6 months apart. So persistent presence of albumin in the urine. This is the label. Second, progressive decline in the GFR. What is the normal glomerular filtration rate? What is the normal?
120.
120 ml per minute.
120 ml per minute.
Exactly, 120 ml per minute. And if it is significantly low, lesser than 90 ml per minute, then we believe a chronic renal failure has started. Okay, so what happens? Diabetes is one of the cause for chronic renal failure, and that what happens slowly. There is decline in glomerular filtration rate. And another one, there is elevated arterial blood pressure. When kidneys are affected, there is always hypertension, always. Without hypertension, I doubt the diagnosis of chronic renal failure. Now, there are two things, One, hypertension develops after renal disease, and if hypertension is there, that will further damage the kidney. So these are some of the very important points. Now, let's talk something more about diabetic kidney. Diabetic nephropathy should be considered in a patient who have diabetes mellitus and a history of one or more of the following. So you are checking a diabetic case, who already gave history. Doctor, I have been diagnosed with diabetes 15 years ago, and you are taking the history of that person. You have to ask these questions to rule out or to suspect diabetic nephropathy. What are these? Ask about passing of foamy urine. Now, what does that mean? If foamy urine is passed, what do you suspect? Yes?
Proteinuria.
Protein.
Proteinuria.
Urine.
Exactly, protein in the urine. Okay, excessive protein in the urine will produce a lot of foam in the urine. So already there's some pathology development, and in diabetic kidney, proteinuria or albuminuria is very common. Another is unexplained proteinuria. Okay, unexplained proteinuria that is found by the lab examination of the urine. Diabetic retinopathy, you have to take history about the vision, okay, about frequent changes of glasses, about some problem in the eye, like that. Because both retinopathy and nephropathy are microvascular complication. Pathogenesis is a bit similar between them, and both of them are a long-term complication of diabetes. If one is there, another may also be there. So that is the relation. Another one, fatigue and foot edema. Okay, fatigue and foot edema. Wait, let me underline this so that you have a good focus here. Fatigue and foot edema secondary to hypoalbuminemia if nephrotic syndrome is present. Diabetes mellitus is one of the important cause of nephrotic syndrome because of the damage of glomeruli. So there is loss of albumin in the urine, okay, which results in hypoalbuminemia. And this hypoalbuminemia can cause fatigability because protein is lost from the body, as well as there is edema everywhere, not only in the foot. It may start from the face in the beginning. Okay, patient may not have recognized that. Later on, the foot edema is there, and the whole body may also be involved. Other associated disorder like peripheral vascular occlusive disease or peripheral arterial disease, you say, hypertension, or even coronary artery disease, if they are there, the pathology has already started and they have a connection with each other. Now, generally, diabetic nephropathy is considered after a routine urine analysis and screening for microalbuminuria between 30 to 300 milligram per 24 hour in the setting of the diabetes. So see there, this is microalbuminuria. More than 300 milligram per 24 hours is a definite proteinuria. So this always start like that. So uh, urine analysis is very, very important. If you suspect diabetic nephropathy, you keep on doing it until you confirm. Patient may have physical findings which are associated with long-standing diabetes, okay, like hypertension, peripheral vascular disease, and we diagnose peripheral vascular disease by palpating the pulses, okay, and that's why we keep on telling our student what are those peripheral pulses. You palpate in the upper limb, in the lower limb, and in the head and neck area. Now see there, in the lower limb, what are those peripheral pulses? Can you answer me? In the lower limbs,
Posterior tibial artery, popliteal artery.
Posterior tibial,
Femoral pulse,
posterior tibial,
popliteal
dorsal
pulse.
patelis, dorsal patelis,
Dorsal aspiratus, posterior.
Tibial.
very good. So
posterior
students, yeah, absolutely, you are answering quite correctly.
Femoral popliteal.
Okay, so they are femoral, popliteal, dorsalis pedis, and posterior tibial. Femoral, popliteal, dorsalis pedis, and posterior tibial in the lower limbs. In the upper limb, they are brachial and the radial, even ulnar you can include there. In the head and neck area, we mainly palpate the carotid artery. Now see there, every student know that on right, okay, on right side, right leg you can say, if dorsalis pedis artery is well palpated, but on the left I cannot feel it properly, that means something is wrong there. Already it may be blocked because of atherosclerosis or those type of pathology. Carotid bruit, okay, can be heard when the carotid artery is narrowed, and again it is associated with atherosclerosis most commonly. Evidence of diabetic neuropathy in the form of decreased fine sensation and diminished tendon reflexes. All of these are chronic complications. That's why we are examining patient like that. Remember, if diabetic neuropathy is there, then there is a high chance that diabetic nephropathy can also be there, and diabetic retinopathy can also be there. That's why you have to examine the whole patient. Non-healing skin ulcers and the presence of osteomyelitis, very common in the foot of the diabetic patient. First of all, what happens? They lose the sensation. After they lose the sensation, they don't realize they are having trauma on the foot, and they don't pay attention properly, so that will further increase into the skin ulcers or complicate into the skin ulcer. If this ulcer is not treated in time, the underlying bone can also be involved, which is known as osteomyelitis. Now, what is the treatment? What is the treatment of diabetic nephropathy? ACE inhibitors are the drug of choice for the treatment. These ACE inhibitors have two important roles here. Number one, it decreases the blood pressure in the body, because hypertension is a very common point in case of diabetic nephropathy. And second, they decrease the proteinuria. So don't forget that. They decrease proteinuria, okay, and then they decrease the blood pressure as well in the patient. By decreasing proteinuria, they slow the progression of diabetic nephropathy. So they are a good drug in this case. All those pril, okay, enalapril, captopril, lisinopril, ramipril, all of these drugs, okay, can be written here. Other issues that are important in the management of this condition include control of high blood pressure, which we have done by using ACE inhibitor, and controlling the blood sugar level with those drugs which we have already discussed. Reduction of dietary salt intake is also very, very important, because it will help in the control of blood pressure. In established case of renal failure, you have to go for routine dialysis, usually hemodialysis. Okay, otherwise the patient has high chance of death. Only two things can be done. One is a routine hemodialysis, another is kidney transplant. Now, the last part of today's lecture, okay, and another important long-term complication of diabetes is diabetic neuropathy. Now, see there, diabetes can damage peripheral nervous system in a number of ways. One, it will block vasa nervorum in the peripheral nerve. These vasa nervorum are very small blood vessels which nourishes the nerve. So if they are blocked, then nerve will suffer from ischemia and they are damaged. Quite easy to understand. The second point, since hyperglycemia leads to increased formation of sorbitol, it's a type of alcohol, and fructose in the Schwann cell. Now, these Schwann cells will be disrupted regarding the function. What is the function of Schwann cell?
They form myelin
Myelination.
sheet in the
Myelination.
Myelination.
in peripheral nervous system.
Exactly.
Axon.
Exactly. They form the myelin sheath in the axon. So if myelin sheath is not formed, the velocity by which a signal get transmitted there is disrupted. It will become very slow. So these are a different problem in the peripheral nerve by diabetes. The earliest functional change in the diabetic nerve is delayed nerve conduction velocity. That's what we are just discussing. And the earliest histological change is segmental demyelination because of the disturbance in the function of Schwann cell. Now, because of this, what happens to the patient? What are the clinical features? See there, the following varieties of neuropathy occur, like symmetrical, which are mainly sensory. So they are symmetrical sensory polyneuropathy. And this is the, neuropathy. So always distal part of the limbs are involved first. Another may be acute painful neuropathy. Third may be mononeuritis multiplex. The different nerves are affected in multiple parts of the body, like cranial nerves or the peripheral nerve. It may be seventh cranial nerve. It may be third cranial nerve. It may be, femoral nerve. It may be obturator nerve, okay, or it may be sciatic nerve like that. Another is a diabetic amyotrophy. Because of the motor nerve involvement, the muscles are atrophied. That is known as amyotrophy. Atrophy of muscle because of motor nerve involvement, which is asymmetrical. And another is autonomic neuropathy. So this is how a diabetic neuropathy occurs.